So a tongue tie is a very common condition and actually quite variable. It's basically where the tongue is more tethered than usual or fixed to the floor of the mouth. So like I say, tongue tie is quite variable. Some are very flimsy and thin, while others are quite thick and fleshy. But tongue ties generally can affect the mobility of the tongue. And so I tell families, especially older children, that they will be better able to lick an ice cream and even better able to French kiss when they're adults. So the mobility of the tongue is really important for these things. The effect on speech is controversial. And so there are certain sounds called front of the mouth sounds like l, t, and s that can be quite difficult to produce if the tongue is not mobile enough. And so there's a lot of work going on to try and answer the question about whether dividing tongue ties improves those movements. And certainly in some groups of patients that would be the case. So by releasing the tongue tie, those front of mouth sounds are much more easy to produce. Whenever babies are first born and starting to feed, especially breastfeeding, a significant tethering of the tongue or tongue tie can affect the baby's ability to latch. So you can get a purr latch. The mother who's breastfeeding will often experience extremely sore nipples. As a result of those two things, there can be an overall per feeding or per weight gain for a breastfeeding baby with significant tongue tie. And that's where the evidence for tongue ties is most strong and convincing. So if you've got a breastfeeding baby who's got any of those symptoms or the mum's got any of those symptoms, then releasing the tongue tie can be a game changer for them. As the child then gets older, there are difficulties with the mobility of the tongue generally. So a lot of significant tongue ties that come to see me, there will be a description of a heart-shaped tongue. So looking at the tongue from the front, it's very much tethered down in the midline and it looks like a heart shape. And that means the baby or the older child can have great difficulty getting the tongue to the front of the mouth past the lips. Things like licking ice creams can be difficult. And so therefore, some of the front of the mouth sounds like we talked about can be difficult to produce with a significant tongue tie. And then as children get older, there's an association with tongue tie and poor dental hygiene. So you can imagine if the tongue is extremely fixed to the floor of the mouth, it can be quite difficult for the child to clear food and other debris from the back of the mouth, and therefore dental caries or dental disease generally is a little bit more common in children with significant tongue ties, and that would be one other indication to consider releasing a tongue tie. So releasing a tongue tie is relatively straightforward. I will release a tongue tie in the clinic without an anaesthetic up to about 3 months of age. And that's really because the baby's head control at that stage is not good enough to move out of the way when I try to release it. Beyond the 3 months, then their head control is just so good that the risks outweigh the small benefits of doing the procedure without a general anaesthetic, and therefore beyond 3 months we would tend to release it under a full general anaesthetic to just improve the safety. Whether it's without an anaesthetic or with an anaesthetic, generally we release the tongue tie with a combination of scissors or especially under anaesthetic with electrocautery or diathermy, and that basically releases the vertical tethering from the tongue to the base of the mouth and improves the mobility, so that at the end of the procedure, the tongue should quite clearly pass the lips and improve the mobility of the tongue and all the associations that we've talked about. So tongue tie surgery involves releasing that vertical tether either with a pair of scissors or sometimes with electrocautery or diathermy. At the end of the procedure, I want the tip of the tongue to be clearly mobile past the lips, and I'll also check either at the end of the general anaesthetic if we're doing it under anaesthetic, or after a short breastfeed if we're doing it in early infancy without an anaesthetic. And the check there is to make sure that there's no bleeding after the procedure, which would be the most common issue that we might encounter. Thankfully, it doesn't occur very often and tends to be self-limiting in almost all cases. Once I'm happy there's no bleeding and that we've released the tongue as much as is required, then the child would just be feeding and going home an hour or two later.